Good afternoon, everyone. On behalf of Federation of Family Physician Association of India, I welcome you all once again for this academic fest of Back to Basics with Dr. Tushar Shah. As you all know, we are trying to keep topics which are of general interest and which are of utmost important to family physician in day-to-day practice. So, looking forward for more such informative webinars from Sir and active participation from all the members of FFPAI. We are still adding a couple of more programs. We are planning a series again on non-academic topics also. Some topics which touches the life of the doctor, like investment, finances, motivation and all, will come out with the more details in the coming time. Without much ado, I will invite Dr. Jashwantji Darbar, the Director of College of GP, Gujarat State Branch IMA, to say something about JSBIMA. Dr. Darbar, please, and once again, welcome to you all. Dr. Darbar, please.
You are muted, Dr. Darbar. Please unmute.
Still you are muted.
Okay.
Yes.
Good afternoon, all. I'm here on behalf of College of General Practice. This College of General Practice is basically one chapter of this Indian Medical Association situated in Tamil Nadu, and each and every state has got its own branch. And this College of GP try to update the all general practitioner on the knowledge front. We also are having many courses like FCGP, which we are giving a postgraduate degree, and so many certificate courses about rheumatology, cardiology, diabetology, and all that. Thank you all to Madam Preeti.
Thank you, Dr. Darbar. Thank you, Dr. Pragnesh. I welcome our speaker, Dr. Tushar Shah, and all the panelists. And to introduce, Dr. Tushar doesn't need any introduction, especially to this group. He has been with us for a very long time, but still he has graduated from Nair Hospital, Mumbai, and he's a consultant physician at Advanced Multi-Speciality Hospital, Mumbai. He is an ardent teacher. His passion is teaching. And we all know how much he has taught us during the COVID times. And he used to say that breakfast is teaching, COVID, lunch is COVID, everything is COVID. So without much ado, I would like to welcome Dr. Tushar Shah. Welcome all the participants too. Over to Dr. Tushar Shah for today's symptomatology, treatment of symptomatology in pulmonology.
Thank you so much, Dr. Preeti, and very glad to be back. We are doing symptomatic treatment in pulmonology, and may I have the PPT, please? This is not the first slide, I think. Can we go to the first slide, please? Yeah, thank you so much. The most important symptom of respiratory disease probably for the family physician is cough. And with so much URTI happening, antitussives are of a significant interest to all of us. So I'll first talk about antitussives. Antitussives or anti-cough medicines, which are principally used for dry cough, to relieve cough. For respiratory use are of two varieties: antitussives which are peripherally acting and antitussives which are centrally acting. The one antitussive which is peripherally acting that we use, all of us are using, is levodopa. Unfortunately, I can't remember these pharmacologic names easily, so I try to remember one brand name of each one. So levocloperazine and levodopa are drugs like Lastus, Resvas, and Rapitus. These I use, but I do believe that their efficacy is much poorer than the centrally acting narcotic drugs or opioids. here the three drugs that I mentioned. The first one, benzonatate, is probably the most useless of the three of them. It's available as Benz Pearls, if you remember. And after having tried it sometimes, I have found it quite useless. My favorite COVID time, you know how Omicron caused a lot of cough. And my favorite COVID time drug was levodopa. However, again, as I said, if codeine was available and was tolerated by the patient, I would prefer codeine far more than the other drugs. So that will bring me to the narcotic drugs. May I have the second slide, please? The narcotic drugs or the centrally acting antitussives are important probably because they're more effective. Codeine, as you know, is the benchmark cough suppressant. And as all of us know, codeine is difficult to acquire or get. But if you can get a hold of codeine, and if you can limit the use by the patient so that they don't get addicted, I think codeine is a beautiful drug for cough suppression. Of course, it comes with the side effects of constipation, which can be severe, mild drowsiness, and some nausea. But otherwise, I would use codeine where possible for a very severe cough. A similar opioid is dextromethorphan. The difference between dextromethorphan and codeine is the dextromethorphan is not as much an addictive substance, so you won't get addicted to dextromethorphan. But at the same time, because it is weaker than codeine, the cough suppression is lesser. The dose of both is very important. The dose of both these narcotics is 30 milligrams 3 times a day. If you give dextromethorphan in formulations which are lesser in content, like Alex lozenges, then you won't be giving a therapeutic dose. The other two drugs are butamirate and coscopin. Coscopin available as noscapin. Butamirate is a newer drug to India, but I don't think it is easily available. These are the other two centrally acting antitussives. The next slide, please. Before we go to mucolytics, I should mention in dry cough, the incidence of postnasal drip causing dry cough or GARD causing dry cough, and what are the therapies for them. How to diagnose GARD or postnasal drip, I'll not talk about here. But if there is a postnasal drip, then probably the best medicine that works is a steroid nasal spray for the cough, a nasal spray for cough, which you have to convince the patient that, okay, I think it is a post-nasal drip causing the dry cough, and I would give a nasal medicine, and it works beautifully. I use fluticasone nasal spray commonly. Occasionally, I will use a fluticasone with azelastine combination for this. The other GERD related dry cough, of course, we all know about. Here, I have just one point to make is that in GERD, we often use drugs like DSR or IT or drugs that contain a prokinetic with a PPI. I would strongly suggest that do not use a prokinetic at all in GERD because they are not known to be effective. There is no evidence to show that GERD improves with prokinetics. What prokinetics should be used like domperidone if there is nausea, significant nausea as a symptom, which happens in acute illnesses, for example. So use a plain PPI. The PPI will take about 2-3 hours to start acting, and once complete acid suppression is achieved, which will be in a few days, then anyway, there is no acid to reflux. And hence, I would not give an anti-reflux or a nausea-related, reflux-related medicine like your domperidone or even etopride, etc. Another caveat, another thing that I like to mention every time here is that the use of levosulpiride has to be stopped completely. Levosulpiride, that is a prokinetic like etopride, mosapride. Levosulpiride has a significant incidence of Parkinsonism. So please stop using levosulpiride. It should be banned across the world, but India still has significant levosulpiride. Yeah, so that is about reflux. And this, of course, the dry cough. Another thing that I often tell is that the dry cough of ACE inhibitors is easy to diagnose because the patient is on ACE inhibitors and they come with cough which has been probably prolonged since a long time. Uh, Sorry, just a second. Sorry. So the dry cough has uh, occurred due to ACE inhibitors. Sometimes that dry cough is missed for months together. But the patient comes to you, he is on, say, Ramipril, and the patient has a dry cough. Diagnose the dry cough as due to ACE inhibitors by asking for one symptom, and that symptom is throat irritation. Throat irritation, of course, is not very specific, but throat irritation should be there for us to say that ACE inhibitor is causing the dry cough. So, in that sense, throat irritation is what we call a sine qua non. Sine qua non is that without which. So, without throat irritation, a dry cough should not be diagnosed as due to ACE inhibitors. So, that is about ACE inhibitors. And if a patient is on ACE inhibitors and has a dry cough, then can we switch from ACE to ARBs immediately? I would do that. Many people believe that if we switch from ACE to ARB, the dry cough might continue due to the ARB. But ARB related dry cough is extremely rare. And therefore, you can easily switch. And if the cough persists after switching to ARB, please look for another cause of the cough. Yeah, so that is about the ACE inhibitor related cough. Now we go to the next group of pharmacotherapeutic agents that is used in cough. There are mucolytics. Mucolytics, what do they do? Mucolytics basically decrease the viscosity of mucus and therefore make it easier for the patient to expectorate. So are mucolytics and expectorants like guaifenesin same? I would say that by definition, mucolytics are also promoting expectoration, and expectorants are also causing lysis of mucus. So I think mucolytics and expectorants is an interchangeable term. The important mucolytics that we have are ambroxol, bromexin, and N-acetylcysteine. A little bit about each, because each has some unique properties. N-acetylcysteine, that you know is a dispersible tablet, uh, is a mucolytic specifically to be used in COPD. So if a patient with COPD comes with inspissated mucus-like features, difficult to expectorate, then instead of ambroxol and bromexin, you can use an acetylcysteine. The problem with N-acetylcysteine is that it has a bad taste and a foul smell, and patients will all often burp and they'll complain that they have a rotten egg smell in the with the medicine. So you may have to change the medicine if that happens. Bromexin and ambroxol, the difference is this, that bromexin comes in tablet form and 8 milligram TDS, as you know, is the dose, and it's very cheap. So the cheapest of the three is bromexin. I have not seen efficacy differences between ambroxol and bromexin in studies. So if you want to give a cheaper molecule, either in a syrup form or in a tablet form, then bromexin might be a good choice to give. Dose is 8 milligram TDS or syrup 10 ml TDS. So that is about bromexin. And then there is ambroxol. Ambroxol is more fashionable, slightly costlier, and again, like bromexin, is available with SABAs, very short-acting beta agonists. One mistake that happens sometimes is that if a patient is on, say, nebulized levosalbutamol or Deolin, which has levosalbutamol, or Asthalin, which is salbutamol, if a patient is already taking inhaled or nebulized salbutamol or levosalbutamol, that is a short-acting beta agonist, please do not give uh, medicines which contain bromexin with terbutaline. As you know, Brozx, for example, is a medicine which contains terbutaline. So don't combine two beta agonists like salbutamol and terbutaline. And so take care of that in your prescription when you write a syrup in addition to an inhaler. So that is about mucolytics. May I have the next slide, please? The other is decongestants. Now, as we all know, phenylpropylamine was a decongestant that was banned because of causing hypertensive strokes. Then phenylpropylamine gave way to phenylephrine, pseudoephedrine, and ephedrine. Both pseudoephedrine and phenylephrine are easily available even now, and they are decongestants. So what do they do? What do they do? They decongest principally they decongest the nose. So pseudoephedrine and phenylephrine are more useful for upper respiratory tract, whereas mucolytics are more useful for the lower respiratory tract in patients with cough. Antitussives are also, of course, useful for dry cough. So phenylephrine and pseudoephedrine uh, typically available in combinations and uh, not alone in a marketed strips. Which one is the preferred one? I prefer phenylephrine because it has lesser cardiovascular adverse drug reaction than pseudoephedrine. Phenylephrine, of course, can cause tachycardia, can cause arrhythmias, tachyarrhythmias, can cause hypertension, can precipitate rarely ischemia in the heart. So, if you are using phenylephrine, I would strongly suggest that you use it only in the younger patient, or you be sure that the patient has no hypertension or no coronary artery disease, cerebrovascular disease. So, phenylephrine can be used, of course, as a decongestant in upper respiratory tract infection. The problem with phenylephrine and pseudoephedrine is they do tend to cause a little dryness, and therefore they are troublesome to some patients. Also remember that phenylephrine comes in illogical combinations sometimes. For example, drugs that contain paracetamol with chlorpheniramine maleate with phenylephrine, that is, for example, Sinus 77 or maybe Sinarest, etc. Phenylephrine keeps the patient awake, and CPM makes the patient drowsy. So the patient doesn't know what to do, sleep or keep awake. So sometimes that is a problem with combination drugs. And as you know, the government recently has banned a lot of illogical cough medicines which come as illogical combinations. For example, sometimes we get a suppressant that is an antitussive with a mucolytic agent, which is ridiculous. So this is about decongestants. Maybe have the next slide, please. And then this is group called expectorants. As I said, I do not know the difference between the definition of mucolytics and expectorants. Mucolytics dissolve mucus, expectorants dissolve mucus and allow expectoration. Both are the same thing. And guaifenesin, which is supposed to be the expectorant of all these drugs, has been proven time and again to be fairly useless. So there are many combinations available with guaifenesin, and I would say that avoid guaifenesin completely because I so don't use it as a mucolytic or an expectorant. As a mucolytic, use the other drugs: bromhexin, ambroxol, and N-acetylcysteine. May I have the next slide, please? Now we come to the antihistamines and their utility. Uh, Antihistamines are of two varieties: first generation and second generation. And remember, this is very, very important that both these generations have different roles to play in respiratory tract inflammation or infection. First generation antihistamines are very well known. We have phenyramine maleate, which we call AVIL. We have CPM, which we often dispense in our from our clinics. Then there is dexchlorpheniramine maleate, which is a brand name is Polarmine. I'm giving brand names sometimes because these are all confusing generic names, and sometimes you don't know which is which. And so dexchlorpheniramine is the dextroisomer of the racemic chlorpheniramine. So if chlorpheniramine is 4 milligrams, then dexchlorpheniramine equivalent is 2 milligrams. Phenyramine maleate, of course, AVIL is a higher dose of 25 milligrams, etc. Then we have diphenhydramine, which we all know as Benadryl. And there is promethazine, which we all know is Finargad. Hydroxyzine, that we know is Atarax. And triprolidine. Triprolidine is a unique molecule in that it is not available as a standalone. And triprolidine is usually combined in syrups with codeine. I will come to that later. So, which one of these and when should you use these? First generation antihistamines are chiefly useful for viral infections where you want to give some antihistaminic uh, uh, medicine. For example, if a patient has influenza and the patient has a runny nose and a cough, dry cough, then you can't use Allegra, you can't use cetirizine, because these are second generation, not useful as much in viral infections or infections in general. So in non infective conditions, use second generation. First generation, use in infective conditions. So you can use any of these, whichever you like. My personal preference is for dexchlorphenamide, which is available at 2 milligram. My dose is 2 milligram 3 times a day in adults, which is what I use. It does cause drowsiness, so you must tell the patient not to drive when using the first generation antihistamines, especially. The second generation cause less drowsiness, but I'll repeat, the second generation are not useful in URTI. May I have the next slide, please? The second generation antihistamines, which are more popular than the first generation ones, cetirizine, levocetirizine, loratadine, desloratadine, fexofenadine, bilastine, avastin, they keep coming. Second generation antihistamines are anti-allergic drugs. They're not anti-infection or anti-inflammation in infection. So use second generation in allergic rhinitis. Sometimes if you want to use in pollution-related cough or allergic asthma, you can use these drugs, but don't use them. I think you should not use them in infections. So in these, what do I choose? I have some views on some of these drugs. One view is that the fashionable new bilastine is not as effective as made out to be. So I'm not extremely happy with the molecule. I'm happier with cetirizine and levocetirizine than with bilastine. Fexofenadine is expensive because the correct dose of fexofenadine, I believe, is 180 milligram twice a day. Once a day does not work as well. It, of course, causes less drowsiness than the cetirizine or levocetirizine. So my choice would be between fexofenadine 180 BD or levocetirizine 5 milligram once a day. It would be what I would choose as an antihistamine in an allergic situation. Maybe on the next slide, please. Yeah. So we are on symptomatic therapy, remember, and we are talking about symptomatic therapy of multiple respiratory diseases, which can be infective, non-infective. So let us come to now something that we use in asthma or COPD or acute bronchitis too. And the first symptomatic group that I'm tackling here is oral bronchodilators. Theophylline, acibrophylline, and then there are other preparations of this group, theophylline group. Uh, we have been using for years, for decades now, and we are so used to this molecule that we have not stopped to think that they are not the best of drugs in bronchodilation, especially after inhalers have come in. So I'll talk about why we should not be or minimize the use of theophylline derivatives as much as possible. Let me talk about salbutamol and levosalbutamol. Oral salbutamol is available, levosalbutamol is available in syrup form also. Just a quick basic fact is that 1 milligram of levosalbutamol is equivalent to 2 milligrams of salbutamol in their oral preparations. Then we have terbutaline, as Aisha said, available in a syrup form. Again, something that I don't use very commonly simply because I like to use syrups as standalone drugs. So, and when you use a syrup, don't combine a bronchodilator with a mucolytic drug. Try to keep each separate so that we don't get confused as to what we are giving. Sometimes we don't even know what is the content of brands like Relitus BM. Venus BM is bromhexine with terbutaline. But we should know the contents of the syrups that we give. That is very important. So at least make a note of that you should not give two sabas, different sabas at the same time. You should not give a mucolytic drug with a cough suppressant or an antihistamine at the same time. So I think we should give single single drug formulations as far as is possible. Bambuterol not available currently easily. Bambuterol is a tablet form of SABA, short-acting beta agonist. I'm sorry, it's a long-acting beta agonist available as an OD dose. It's a pro drug probably. I'm not sure about this, but it is available in 20 milligram and given once a day. It used to be available. I have used it in the past, but I don't think it is available now. There is another beta agonist available as a patch in a patient, say, who is moribund, cannot take orally. I'm forgetting the name, and I'll remember it just now. Or maybe Dr. Kumar or somebody can help me remember the name of the patch. मेरा लेक्चर 5:30 तक है, बिठाओ ना, या तो ऊपर दिखाने का पहले ऊपर दिखा दो, कुछ अर्जेंट है. Okay, sorry. So that is oral bronchodilators. I'll be talking about the theophylline in a bit. May I have this next slide, please? Inhaled bronchodilators. Bronchodilators are per se symptomatic treatment, as against steroids, which are actually therapeutic agents in that they prevent asthma, etc. So bronchodilators are symptomatic treatment, especially the short-acting ones. The long-acting ones are used as prophylactic agents. So what are the short-acting bronchodilators used in acute situations? There are two, salbutamol and levosalbutamol, available as inhalers. Here, everybody knows about them, so I'm not detailing much, but one or two pointers. Again, salbutamol 200 micrograms is equal to levosalbutamol 100 micrograms. So that you will see on the formulation themselves when you use the inhalers. My strong suggestion is that stop using the regular uh, dry powder inhalers like what we call rota caps. Stop using them completely because the deposition, even though the dose is double, for example, if in a asthalin inhaler there is 100 micrograms per puff, in an asthalin rota cap there'll be 200 micrograms of salbutamol per puff. Even though the dose is double in the rota cap, the efficacy is poor. So if you want to use something like a meter dose inhaler, use a discus or a disc instrument. For example, Senatide AccuHaler used to be a disc instrument, which is not easily available. Seroflow SIP Haler is a disc instrument, which is available easily. So use a disc instrument because that probably gives a better powder form and it gives a better reach than your rota caps. Rota cap use should completely stop, in my view. Also, please tell the patient to rinse mouth more than once and gargle so that both the throat and the oral cavity are cleared of the inhaler, whether it's rota cap or meter dose inhaler or in nebulizer for that matter. You must clean the mouth. Besides, of course, the inhalers, the dry powder, and the metered dose, we have the nebulizations. And many patients who have significant asthma, if their asthma is chronic and they have difficulty taking in or coordinating, do advise a nebulizer. Nebulizers are far more effective than any inhaler. And except for the inconvenience of using them, you should be able to get a better result with the nebulization. Many patients develop a habituation to short-acting beta agonists called SABAs, and this is disaster because we know that SABAs cause increased mortality if used on a regular basis in asthmatics. Very important. I'll repeat this and I'll repeat once more later also. Repeated and regular use of short-acting beta agonists like salbutamol and levosalbutamol increase mortality in asthmatic patients, which is a sad thing. You're giving a treatment which actually will cause death. So don't allow them to take SABAs for long term. Another thing that often happens is about a brand. I'll have to name the brand. There is something called Aerocort rota caps, Aerocort Fort rota caps. Aerocort is a drug which obviously contains a beta agonist and a steroid, ICS. ICS means inhaled corticosteroid. This contains salbutamol or levosalbutamol, Aerocort. You cannot use Aerocort as a prophylactic drug for patients because it contains the short-acting beta agonist. So remember to see the content. Do not allow short-acting drugs to be continued for a long time. They are not prophylactic drugs. Short-acting drugs are SOS drugs used when necessary. So that is about the short-acting beta agonists, which are symptomatic drugs. The long-acting beta agonists are actually prophylactic drugs. So we have for asthma, we have longer-acting drugs called salmeterol, formoterol. There is also R-formoterol if you are interested. And then there is ultra-long-acting in the form of indacaterol, etc. These are not symptomatic drugs and therefore not in the purview of our discussion, but just to make the beta agonist list complete. So the first ones are SABA, short-acting beta agonists. The second and third ones are LABA, long-acting beta agonists, and ultra-long ABA, ultra-LABA, ULABA, ultra-long beta agonists. So these are the three kind of beta agonists we have principally used in asthma. Can we use beta agonists in acute bronchitis? Yes, we can. And therefore, salbutamol, levosalbutamol will become useful even in acute bronchitis. May we have the next slide, please? Okay, so this is just a THM. THM is something that I call a take-home message. When a patient has, you prescribe patient of asthma, both a SABA for SOS use and a combination of ICS and LABA, then you must teach them how to use it in acute asthma at home. You tell them that you can take nebulized levosalbutamol, 0.63 milligram wala. You know that is levosalbutamol comes in three strengths: 0.31 for pediatric use, 0.63, and the double that strength, 1.25. So if you have a patient who takes SOS, who wants to take SOS medication, tell them to take levosalbutamol 0.63 milligrams, which is contained in 3 ml of the nebulizing solution, and give it as nebulization. And you can give 3 doses maximum every 20 minutes of nebulized levosalbutamol before they decide, okay, enough is enough, and they will need to go to the hospital. One of the indications of going to the hospital will be failure of 3 doses of nebulized levosalbutamol given 20 minutes apart. What we will often do is, if such a patient comes to the clinic, we will give them injection deriphylline. I would strongly suggest keep a nebulizer in your clinic and use this method of nebulization, giving 3 doses 20 minutes apart, more than giving theophylline, because theophylline has significant side effects, which we will come to. So this is one way of treating acute asthma. What if the patient does not have a nebulization machine? May I have the next slide, please? If a patient has no nebulizer or it's not available easily, then the patient can take 4 to 8 puffs of salbutamol inhaler every 20 minutes for 3 doses. What is salbutamol inhaler? Each salbutamol inhaler, uh, uh, 200 micrograms, you have to take 1 inhaler every 4 puffs every 20 minutes via a spacer device. Spacer is a must. Spacer, you cannot be lazy in this matter. You have to prescribe a spacer device if the patient is on meter dose inhaler, and you have to teach them how to use a spacer. Now, enough YouTube videos are available for them to see how to use a spacer. So 4 to 8 puffs of 200 micrograms salbutamol every 20 minutes for 3 doses. If they are using levosalbutamol, then the number of doses become same, because the amount of levosalbutamol in each puff is now 100 micrograms. So 4 to 8 puffs of levosalbutamol or salbutamol every 20 minutes for 3 doses is what you would give as a maximum dose before you decide, okay, this patient is not getting better and will need either hospitalization or some form of parenteral therapy, maybe even oral steroids. May we have the next slide, please? So salbutamol meter dose inhaler has 100 microgram per puff. I made a mistake of saying 200. I'm so sorry. 100 microgram per puff, while levosalbutamol has 50 micrograms per puff. Rotacaps have 200 and 100 micrograms per puff of salbutamol and levosalbutamol respectively. Next slide, please. Bronchodilators are not just the beta-2 agonists. Bronchodilators are also muscarinic antagonists of the anticholinergic drugs. These are also bronchodilators. Short-acting ones are the ones that are used for symptomatic therapy, and long-acting ones are the ones used for long-term prophylaxis. As you know, inhaled bronchodilators of the muscarinic antagonist types are principally used in COPD, but they can be used in asthma too. So, which in acute attack of asthma or in acute exacerbation of COPD, the drug used is ipratropium. Ipratropium is the drug of choice in COPD exacerbation and in asthma exacerbation if the patient does not tolerate SABA, that is short-acting beta agonists, because of tachycardia or any such reason, then you can use ipratropium as a single drug for relief of asthma, or you can use a combination, as you know, Duolin, for example, is a combination of SABA and SAMA. Ipratropium with levosalbutamol is the combination called Duolin, for example, a brand name. You can use in asthma a combination of ipratropium and levosalbutamol as a symptom reliever. Many patients respond better to that than levosalbutamol alone. So that is a couple of things about ipratropium. Ipratropium is an acute drug, a drug for symptom relief. It's an anticholinergic. So ipratropium can cause a dry mouth, as you all know. One of the biggest mistakes made in outpatient practice and in home self medication by patient is patients keep on taking Duolin, TDS or BD or whatever dose for long term. Again, remember, Duolin is short acting, both SABA and SAMA. If you take Duolin for long term, you are going to increase mortality for the patient. So you have to switch from Duolin to, for example, Diova. Diova is long-acting tiotropium and long-acting salmeterol or formoterol is it. One of the long-acting beta agonist and a long-acting uh, anticholinergic drug or muscarinic antagonist. So you cannot give Duolin on the long run. It has to be limited to few days at the most. Another thing about ipratropium is ipratropium can precipitate angle closure glaucoma, like tiotropium also and glycopyrrole also. These are all anticholinergic drugs. They can precipitate angle closure glaucoma. And how do you know? Angle closure glaucoma is an acute illness. It doesn't happen in patients who have chronic glaucoma. It happens suddenly. So how do you know? It is very difficult. So we have to see the angle between uh, uh, the cornea and the iris. And if the angle is short, so an ophthalmologist can make out if it's a very acute angle, giving ipratropium, tiotropium can suddenly cause acute headache, red eye, and congestive glaucoma. So that is one side effect of. So how do you prevent if you think that the patient is narrow angle? Then how do you give ipratropium? Don't give it by a mask because mask will have fumes which will go to the eye. Give it by a pipe, that mouthpiece that goes straight in the mouth. Might be a little better. Ipratropium, tiotropium, etc. can also precipitate retention of urine in patients who already have significant prostate enlargement. So that is one thing that you might have to tell the patient that, okay, if you don't pass urine for several hours, then you may want to uh, recheck with the physician, check your prostate size, etc., and stop the anticholinergic drugs. Yeah. May I have the next slide, please? So again, this is a repetition, but it's worth repeating. SABA and SAMA are for symptomatic relief, while LABA and LAMA are for the prevention of asthma and COPD respectively. I'll just, because it is all very confusing sometimes to all of us, SABA is short-acting beta agonists. Short-acting beta agonists are principally salbutamol and levosalbutamol in the inhaled form, or terbutaline, for example, in the oral form. SAMA is short-acting muscarinic antagonists. Did I say SABA is short-acting beta agonists and SAMA are short-acting muscarinic antagonists? And these agents, SAMA, include ipratropium, which is, there's only one short-acting drug called ipratropium. Tiotropium and glycopyrronium are longer-acting or LAMAs. LABA is, many LABAs are there, long-acting beta agonists. You know formoterol, which is very popular, salmeterol, which is very popular. And in LAMA, we have the most commonly used LAMA, that is muscarinic antagonist, long-acting, is tiotropium. So these are LABA-LAMA are for prevention, SABA-SAMA are for symptomatic relief. Maybe have the next slide, please. Now that brings us to the most popular drug for asthma in India. And the most popular drugs that is of the theophylline group. So we have tablet derifylline, for example, which is a combination of, I think, etophylline and theophylline. Then there is injection theophylline, aminophylline, that is, which we give intravenously, injectable derifylline that we give intramuscularly, and then there is theophylline orally, and then there is acibrophylline, and then a couple of more phylines are available to us. Now, theophylline derivatives are losing favor all across the world except in India. They are no longer favored because they are weak bronchodilators. The most important thing, we have now inhalers, nebulizing solutions, and even metered dose inhalers are more effective than theophylline. Theophylline do not have anti-inflammatory properties. Now, as we know, asthma is an inflammatory condition. So, steroids, for example, will be anti-inflammatory, whereas theophylline is not. Theophylline, as you know, has numerous drug interactions with simple drugs like ranitidine and antibiotics like quinolones and clarithromycin. They have a low therapeutic to toxicity index, meaning, for example, if you give theophylline intramuscular, the patient can, if predisposed, get severe palpitations and even tachyarrhythmias. Intravenous aminophylline can cause convulsions. So this is one reason why gradually theophylline is falling out of favor. Even my pen still writes sometimes acibrophylline or derifylline. But I think we should restrict the use because we should not be lazy about prescribing inhalers or teaching correct inhalational techniques to the patient. May we have the next slide, please? Symptomatic treatment, the other drug group is nasal decongestants or anti-allergic drugs. When the nose is blocked, we do steam inhalation, which is a symptomatic treatment. Some people do what is called the jalneti, that is a yogic exercise to clean the nostrils. We have saline sprays marketed where you spray an expensive solution of salt into the nose and clean the nose. It's effective. And then we have the vasoconstrictors, which are nasal decongestants, oxymetazoline and xylometazoline. And then we have anti-allergic drugs. So where are they used? So the saline spray, oxymetazoline and xylometazoline are, of course, used for acute treatment of symptomatic relief or symptomatic relief. A couple of words here about oxymetazoline and xylometazoline. Basically, is that these drugs, these vasoconstrictors of the nose, they cause significant rebound congestion when stopped, if used for several days. So if you were to, the patient uses, say, Otrivin nasal spray or Nazivion, whatever the brand names are, for multiple days, 3 to 5 days, and then continues using them for 10, 15 days. When they stop the medicine, they get a rebound, significant nasal congestion. Now, this is a little different from what is called rhinitis medicamentosa. Rhinitis medicamentosa is a chronic rhinitis which continues and which occurs due to abuse of these nasal sprays. Where nasal sprays are used, they cause vasoconstriction, and then after the effect goes away, they cause vasodilatation occurs and again congestion. And this cycle of decongestion and congestion cause chronic inflammation of the nasal mucosa, causing chronic rhinitis medicamentosa. So you must talk about these sprays and tell them not to use for more than 5 days. I'd say 3 days usually, because 3 ka 5 ho jata hai, but not more than 5 days definitely. Then we have the third form of nasal spray, which is either a steroid or a second generation antihistamine given nasally called as elastin, and a steroid like fluticasone. You can use fluticasone alone, you can use azelastine alone, or you can use them as combinations as nasal spray. Couple of things here. We'll come to that again probably. And azelastine is a second generation antihistamine, not very useful in viral infections. So in viral infections, give oral antihistamines of the first generation. And if you need to give a steroid spray, give fluticasone alone. Fluticasone is unique in that respect that the nasal spray of steroid is effective both in allergic conditions and infective conditions for symptom relief. So I love the steroid spray, especially I like it in influenza. For example, if the patient is sneezing incessantly, does not like to take cetirizine or any other antihistamine or polyramine, for example. In influenza, we give polyramine more. If they don't like to use these antihistamines because of drowsiness, I use fluticasone intranasally. It works well for even in viral conditions, not just in allergic conditions like allergic rhinitis. So acute use of nasal steroids is also probably effective. May I have the next slide, please? Montelukast and cifrelocast and the other leukotriene inhibitors. What is the role currently of these? So montelukast is not an acute medicine. It is not. It is a preventive medicine. Do not use montelukast to treat an acute asthma attack. Patient comes to you, don't give darifilin, retard 150 BD and Montelc at night for an acute attack of asthma. That is incorrect. Montelukast is used to prevent symptoms of asthma. One dose, the one thing, it's a preventive, right? So if a patient does, I'll come to that. So I'll read this sentence first. One dose can be given 2 hours prior to exercise to prevent exercise-induced asthma. If the patient says that, okay, I am going to climb a pilgrimage mountain in Gujarat and I get asthma when I climb the mountain, can you give me some preventive? So you ask that patient to carry levosalbutamol inhaler with them, but prevent the exercise-induced asthma with uh, 10 milligrams montelukast given 2 hours prior to the climbing of that mountain. So this is a very useful molecule to prevent exercise-induced. The term used now is not exercise-induced asthma, but exercise-induced bronchoconstriction, which is fine. So this is what the utility of montelukast is. There is more to montelukast. Maybe on the next slide, please. Maybe on the next slide. Yeah. Montelukast as an asthma prophylactic may be used as monotherapy in patients intolerant to inhaled corticosteroids or as an add-on to inhaled corticosteroids. Now, this is an important issue. Many patients will get repeated fungal infections when they use inhaled steroids, even if they take the utmost care. They may be diabetic, they may be non-diabetic, but if they get repeated fungal infections due to inhaled corticosteroids, you have a choice of switching to montelukast as an asthma preventive. Now, the good thing about montelukast asthma preventive is that it is a tablet, no oral fungal lesion. The bad thing is long-term montelukast has now been associated with serious mental health side effects, including depression, severe restlessness, etc. So you'll have to take your call as to whether you would like to use montelukast. Another thing that can be done is you can keep the dose of inhaled corticosteroids low by adding montelukast. So if a patient is not tolerant to steroids, or some patients do develop systemic side effects of inhaled corticosteroids, then these patients you might give a lesser dose of inhaled steroids and add a montelukast as a prophylactic. Next slide, please. Okay, now we are coming to some drugs that are, well, unusual. Is oxygen a symptomatic drug or a therapeutic drug? Is a question that can be debated easily. In hypoxic patients, if you give oxygen to the patient, it gives symptom relief for sure. They'll feel relieved in the shortness of breath, in the fatigue, in the dizziness. They'll feel alert and they can sleep better when they have to sleep. So oxygen is a symptomatic drug in patients with acute or chronic hypoxia. May we have the next slide, please? An important drug in symptomatology of respiratory disease is morphine. We all know morphine as a drug used for pain, like cancer pain, for example, terminally ill patient cancer pain. We all think of morphine or fentanyl. However, morphine is a great drug for bad breathlessness of a terminally ill COPD patient or lung metastasis patient, for example. And you have to give a small dose 1 milligram twice a day or up to 5 milligram 3 times a day, I never start morphine on my own. I'll always take consultation from a palliative care specialist. And then we teach the patient how to titrate the dose and give the dose. So morphine is a good symptomatic reliever of terminal breathlessness. Next slide, please. Now, let me come to some unusual facts that about symptom relief. Of course, we have not completed the whole system. There are a lot of things that I must have missed, but one unusual fact is that honey, uh, our grandmother's recipe, is superior in studies in the UK. They have shown that honey is superior to dextromethorphan as a cough suppressant or antitussive in children with URTI. An interesting fact and something that we may follow. Next, please. Drugs like Cinerest, as I've already told you, contain CPM that cause drowsiness and phenylephrine that cause insomnia. So you can take your call. I do sometimes in patients who are prone to insomnia, avoid giving Cinerest at bedtime. Next, please. This is a very important area, post-infectious cough. There is a name for it, I forget it, but long-standing post-infectious cough. Patient gets viral URTI like COVID, for example, and this Omicron leaves behind weeks of cough. And we are all often flummoxed. We are often uh, not sure as to what to do. We try many syrups and nothing seems to work. So there are several options in this cough. If any cough persists beyond 3 weeks, you can try oral steroids, which is obvious, but we can try
You're
inhaled
muted,
steroids
sir.
like your budesonide, etc. Or you can even try anticholinergic drug, ipratropium inhaled. So these are the options that you have. One more option that we have for, I've not written here, but for post-infective or post-viral cough is unusually using pregabalin and gabapentin. These two drugs have also been known to reduce the degree of severe cough. If the cough is intractable, that is one thing that you can use. Gabapentin dose recommended is 300 milligrams. Pregabalin dose recommended is 75 milligrams. Use either of these first, start at low dose and then go up. Maybe it is useful. I have not used it ever, but well, there is good literature for that. Maybe on the next slide, please. Alex, lozenges. All lozenges, I think, are placebos. All lozenges given for cough are placebos. Placebos act, as we know, placebos have sometimes an efficacy of 30 to 40%. So you can give them as placebos. But dextromethorphan plus lozenges like Alex have 5 milligrams of dextromethorphan. And the correct dose is 30 milligram 8 hourly. So you have to pop in 6 lozenges at a time in your mouth if you really want some efficacy. So it's not useful. Uh, you should also see the doses in each brand that you give so that you're giving the correct dose. For example, Ascoril D12, it's called Ascoril D12. I don't know why it's called D12, but Ascoril D12 has 30 milligrams of dextromethorphan in 5 ml of the solution. So you can give 5 ml 3 times a day to get the correct dose. Yeah, next slide, please. So I already told you this, that frequent SABA use paradoxically is associated with increased asthma mortality. So this is one thing that you must keep on inquiring with the patient. Are you using too much of Astalin or levosalbutamol, Levolin, and please stop using it. Next slide, please. Okay, I think I've come to the end of my presentation. A couple of drugs that I did not talk about, which I should. One is modafinil and R-modafinil. In obstructive sleep apnea, for symptom relief of daytime drowsiness, we know that there is modafinil and R-modafinil available. Uh, the patient is say uses BiPAP in the night or auto CPAP in the night and still remains drowsy in the daytime, then you may want to add 200 milligrams of modafinil or 150 milligrams of R-modafinil. That is, one brand name is Mod Alert for modafinil, Wake Alert for R-modafinil. You may want to start one of these two drugs to keep the patient awake in the daytime, especially if their job entails alertness. So that is one symptomatic drug that I could not talk about. Yeah. Another area that I think is interesting is there are many patients who have aspirin exacerbated respiratory disease, AERD. It used to be called aspirin-induced asthma, AIA. Now the asthma term has been removed because it does not behave like typical asthma. So AERD is a condition where aspirin causes an acute attack of asthma. Now, when it causes asthma, uh, you can of course treat it with acute inhalers like salbutamol, etc. How do you prevent AERD? Because aspirin has cross reactivity with many NSAIDs. So if a patient has AERD, all the non-specific NSAIDs like diclofenac, ibuprofen, naproxen, etc., will also be probably causing the same exacerbation like aspirin does. So what does not, which NSAID can be used in patients who have aspirin sensitivity? Then the COX-2 inhibitors come into picture because they do not cause the same degree of bronchospasm in patients who have AERD. Within COX-2 inhibitors, there are very selective COX-2 inhibitors like celecoxib and etoricoxib, both available in India. I'm a strong opponent of celecoxib and etoricoxib because they have significant cardiovascular morbidity. So I would, if I had to use a selective drug as an NSAID in a patient with aspirin respiratory disease, then I would use either etodolac or nimesulide. Nimesulide is notorious for some hepatotoxicity. So my drug in such patients who have aspirin exacerbated respiratory disorder, my choice is etodolac, which is not the same as etoricoxib. Etodolac is partially COX-2 selective. So yeah, that is about it from my side. Uh, we can have Dr. Preeti some questions.
Uh, Thank you very much, sir, for a very informative on all the symptomatic drugs. There is one comment by Dr. Abhay Bargaonkar who says that reflux esophagitis is a non-pulmonary cause of thing. You agree with it and he wants to just discuss on that.
Uh,
Reflux esophagitis.
any kind of reflux, acid reflux, or
Yeah.
bile reflux, for example, can cause cough, and it's a non-respiratory cause of cough, like ACE inhibitor cough is also a non-respiratory cause of cough. And so when I get a patient of cough who I'm not sure is whether it's a reflux or it's a post-nasal drip or it's a post-viral cough, uh, some people will do is they will give a PPI and they will give a montelukast or a levocetirizine or a fexofenadine kind of drug together. One thing that I never do, because I need to diagnose by giving the therapeutic modality, one thing I never do is I don't treat two things together. You must treat either one of them so that you can make out what caused benefit. If I give only a pantoprazole or an omeprazole and the cough subsides, then I know and I can tell this patient because reflux cough can keep on occurring if the patient has, say, for example, a hiatus hernia. Then I tell the patient, your cough is a reflux cough, and you must therefore take every time a PPI, do not take your antihistamines. Another situation that comes up sometimes here, I'm sorry, is if a patient comes with significant cough and the patient has pollution around, construction work is rampant in most of the metros that we have, and many patients because of pollution are getting cough. How do and I do a CBC, I do an X-ray chest, etc., etc. I don't find any cause of the cough. How do I treat this cough? What sometimes I do is I give it a therapeutic trial of steroids just as we give therapeutic trial of PPIs in suspected reflux. I give a therapeutic trial of steroids in suspected allergic cough. It may be an inhaled steroid. Occasionally, it may be in a young patient, a short course of oral steroids. If steroids dramatically improve cough in a patient, it cannot be acid reflux because steroids would worsen acid reflux. So it can be either a postnasal drip or an allergic cough. So giving steroids, inhaled steroids will not treat a postnasal drip. So you have modalities which are therapeutic. to diagnose the condition. So I think one would use that. Yeah. Thank you.
So I have a question for you, sir. At what stage does a family physician, I mean, you get fed up of treating 3 months, 3 weeks, 4 weeks. When do we refer to a pulmonologist or to you?
First of all, the patient has to be fed up of you for you to refer the patient to somebody else. But yeah, I don't know if there is, but if I find constitutional symptoms like weight loss, for example, or a low grade fever that has started happening, uh, these are red flags. Obviously, if the patient starts getting hemoptysis, for example, even once, it's a red flag for me. So if there are red flags, you will definitely investigate more or refer. What I would suggest to all of us, to all the journalists here, is that we are a little tardy, we are a little lazy in investigating any symptom, whether it is acute fever in monsoon or it's a dry cough which has persisted beyond 3-4 days. Once a dry cough persists beyond 3-4 days, please do at least a CBC, or if you want, if 15 days have passed, then maybe an X-ray chest. And you can be easily surprised by a CBC showing an eosinophil count of 3,000, and you will know that okay, you're dealing with something other than your standard cough. So I would say investigate early rather than late, because that is when you will be able to obviate referring unnecessarily, or truly refer quickly if the patient has gross abnormalities on the investigation. So yeah.
No more questions. Over to Dr. Sanjay.
Thank you, Dr. Tushar Bhai.
Welcome,
You
sir.
have given a very good guidance for us, all of family physicians, and we get the good knowledge about different pulmonological symptoms and different disorders also. This was your second lecture, and we are very happy to listen you every time. And we will have you again on the next month. Thank you, sir.
Thank you so much, sir. Thank you very much. Bye-bye.
Thank you all the participants.